Good afternoon, everyone. Thank you so much for joining this NASHP webinar. I'm just going to give it 1 minute or two to let people get on, and then we can get going. Okay, great. Welcome, everyone. We are going to be discussing the model law that NASHP recently developed at the request of and with the direction of state officials to help address the corporatization of healthcare. Since releasing our model, we have gotten a lot of questions, and so we are pulling this webinar together to help provide information and hopefully answer your questions. I want to flag for everybody, we will be monitoring the Q&A, so please feel free throughout the webinar to post your questions. However, we are going to wait until our speakers get through their presentation to address those questions. We are so grateful to have legal experts who participated in our model development work group for many months with state officials. Here today, Erin Fuse-Brown and Hayden Rook-Lee, who are going to walk through this very comprehensive model. I will just flag from the beginning, and you will hear it from our speakers, that we at NASHP know this is a sort of complex comprehensive approach to policymaking. It is designed so that states can take the provisions that they want to take and not necessarily have to pursue the entire model. The goal in developing this really came from state officials who are eager to address, again, the corporatization of healthcare, consolidation and rising prices, the inclusion of private equity and other investors, and sort of the opacity of ownership really has driven state officials to ask for this model. So there are provisions within this to increase understanding of the market for state officials, to strengthen physician ownership and clinician decision-making, and improve overall transparency of ownership. So as we get going into this discussion, I just want to remind folks again that we are going to use the Q&A function, not the chat. We are recording this webinar so that we can post it afterwards and archive it on our website so that folks can reflect back to it. We will share the slide deck along with that archived webinar. But with that, I'm just going to thank Arnold Ventures for supporting this work, and then turn to our legal experts to kick us off. And I'm happy to turn the mic first to Erin Fuse-Brown. Thank you so much for being here.
Thank you to NASHP Maureen for that terrific introduction. And I also wanted to thank Arnold Ventures for supporting this work, but really the work and ongoing help of the state work group that really, as Maureen said, drove a lot of the detail in terms of both the policy objectives and also to inform what kind of concerns they're hearing about in their states. So a lot of this was the result of a lot of collaborative work. So thank you to that work group. I'm going to share my slides so that we can advance the discussion. All right, so as I mentioned, what motivated, or what Maureen mentioned, is what motivated this model were states' ongoing efforts to increase affordability, that's a very big touchstone, as well as access to high quality care, acknowledging that there are gaps in current sort of legal protections, oversight, including gaps in federal antitrust law, to address sort of the increasing and new forms of healthcare consolidation that's happening. A lot of these transactions may be driven by entities like private equity, insurance companies, retail giants, and other corporate actors. A lot of times, however, particularly when these transactions involve physician practices, these transactions are too small or take forms that are not well monitored by traditional antitrust tools. but they are having the same consolidating effect on markets. They're showing up as rising prices. They also, in many instances, can also manifest as loss of access to services, whether it's that providers exit insurance networks or key facilities or service lines are shuttered and closed. And that makes healthcare both less affordable and less accessible within the state. And states are very interested in taking steps to oversee, to monitor, and provide some oversight over this type of healthcare transaction and consolidation, corporatization, but also to protect the healthcare provider workforce from undue financial pressure and burnout from corporate control. So the new NASHB model, I will advance the slide here, consists of three main policy approaches for states to deal with corporate consolidation in healthcare. And as Maureen mentioned, these three parts are viewed as mutually reinforcing, but they can be pursued on an a la carte basis or in sequence. So states don't necessarily have to take on the entire model all at the same time, but they can bite off pieces of it that might work to address the concerns that are most salient in their state. So the first policy is for states to create a stronger authority to oversee healthcare transactions. And here, of course, the policy concern is this sort of inadequacy of current antitrust tools and oversight and visibility, frankly, into the type of healthcare transactions that are currently contributing to consolidation and increased cost. These include the types of transactions that we see, for example, that private equity has pursued with hospitals and nursing homes in the past, leading to most famously the Steward Healthcare debacle, and those are the sale leasebacks and the stripping of real estate assets, but also the types of management services agreements and staffing contracts that a lot of these entities undertake that don't look like out and out ownership acquisition, but rather are contractual control. So including those explicitly in the type of transaction authority is necessary. The second policy is for states to increase protection for physicians and others in the healthcare workforce from growing corporate control through stronger regulation of the corporate practice of medicine, through regulation of the use of restrictive covenants like non-competes and non-disparagement clauses. And Hayden is going to talk about that when we get to those pieces. And then the third policy addresses the lack of transparency into this complicated ownership and control web of relationships among healthcare entities. And without this information, it becomes very difficult or impossible for regulators, enforcers, and even researchers to study the effects of this type of corporatization of healthcare. So I'm going to turn first to the first part of the model, and this is the enhanced oversight over material healthcare transactions. So many states have already started the process or have created enhanced oversight authority to review certain types of healthcare transactions. A lot of times they focus on the traditional sort of nonprofit hospital mergers, but many states have gone beyond that to include other types of healthcare transactions. But in some this enhanced oversight authority has typically been limited to a relatively narrow range of transactions. Again, those involving nonprofit hospitals are probably the case in point. There is a concern that these traditional oversight tools do not fully address the contemporary trends of consolidation. This includes vertical acquisitions, contractual affiliations, private equity investment, investment by payers, such as Optum, and smaller serial transactions, meaning transactions that are pursued on a one-by-one basis that have a consolidating effect in cumulative total, but don't pose particular market concerns on an individual basis. So several states have already enhanced oversight authority over healthcare transactions by requiring both prior notice of all material healthcare transactions, expanding the authority of those in the state, whether it's the Attorney General's office, the Department of Health, or some other health agency, to review these transactions for concerns, particularly antitrust concerns, but other types of market concerns. And then in some states, there is an enhanced ability to block or impose conditions on these transactions without seeking a very expensive and resource-intensive court order through litigation and enforcement. So these the traditional legal standards that apply to these transactions that almost every state possesses already, antitrust law, charitable trust doctrine, again, don't capture all the potential concerns raised by these deals. They're usually limited to price effects or market power effects. So It may not, for example, this review may not address the effects on the workforce, or it may not address the effects on the continued availability of key service lines in rural or small communities, or on quality impacts, or on equity concerns about how this might affect vulnerable populations differentially than others. So some states have vested the authority for transaction and health and oversight in a health agency of some sort, whether that's within the Department of Health, whether it's by creating a health policy commission or healthcare market oversight commission, to share in the review process in order to pursue evaluation of these public interest concerns that are not necessarily in the purview of an antitrust, attorney general antitrust review. So what does the NASHB model do? So NASHB had previously released a model law to enhance healthcare transaction oversight based on the laws in leading states such as Massachusetts, Oregon, and California that have expanded oversight in this way. However, in the process of developing this model, we heard that there are still many transactions that are falling between the cracks, even in this most robust version of oversight. So we set out to update the sort of 1.0 version of the model with a 2.0 version for reviews of material change transactions. And in particular, states were concerned that even enhanced oversight authority was still missing service line closures or facility closures that are the result of healthcare consolidation, sale leaseback arrangements that private equity firms use to strip real estate assets from hospitals or nursing facilities, or the use of management services agreements or staffing company contracts that corporate entities use to control physician practice without outright ownership. So in particular, the new 2.0 version, the 2024 model, does the following. First, it expands the type of entity, the scope of entities that are covered by transaction oversight. It explicitly extends oversight to private equity-backed healthcare transactions, transactions including agreements involving management services organizations, real estate investment trust transactions, so those sale leaseback type arrangements, transactions involving healthcare providers and provider organizations with payers, so think those sort of United Optums of the world, and also staffing company arrangements. It also expands the scope of transactions that are covered along with that sort of expanded type of entity, including those sale leasebacks, the MSO agreements, serial transactions, meaning those cumulative transactions that may, again, be too small individually, but to be able to look back over 5 years to be able to accumulate their market impact. Joint ventures, closures of key facilities or services are now noticeable, reviewable transactions under the new model, and staffing agreements. And then finally, the final piece of this is also to increase the enforcement authority or clarify the enforcement authority of the various state entities. So the Attorney General continues to possess, as it always has, enforcement authority under the antitrust laws, under consumer protection laws, and the ability to impose penalties and seek injunctive relief, but also to create a level of administrative oversight on an ongoing basis in a state regulatory agency, whether that's the state health department or the health commission or other entity that is created and tasked with that authority, and then to provide ongoing monitoring of transactions, not just for 5 years, but really to study the market impacts of these transactions well into the future in order to provide oversight over bad behavior that might extend beyond a typical consent or settlement enforcement period. So that's sort of to summarize the first part, and I want to turn it over to Hayden to talk about the next set of policies, which is in part 2 of the model to strengthen protection for physicians and other healthcare clinicians.
Great. Thanks, Erin. And thanks, everybody, for joining us here. As Erin mentioned, I'm going to talk a little bit about this second component of the bill on the corporate practice of medicine ban. Erin, if you want to slide forward. So the main concern, as Erin and Maureen have referenced here, that we've heard from states is this concern that various types of corporate entities, whether they're private equity-owned companies or insurance conglomerates or retailers or certain hospital systems, may be exercising an impermissible level of control over medical practices and over clinical decision-making. So that's the policy concern. And as it turns out, this is a longstanding concern that states have dealt with for decades, this sort of conflict between making decisions in the healthcare system and pursuing corporate interests to maximize business interests. So states have actually through courts, through common laws, through state-made common law, and increasingly through state legislatures, enacted forms of what's known as the corporate practice of medicine. And these laws, this doctrine in courts generally ban unlicensed lay entities from owning, employing, or controlling medical practices. The most common version of this that we see still in most states is the requirement that a for-profit medical practice is actually owned by licensed physicians, and depending on the scope of practice laws in the state, is owned by other clinicians that, again, that are licensed to practice medicine in the state. So you might ask, well, if states have these laws that, again, require that physicians and other clinicians that are licensed in the state actually own their medical practices, how is it that these different corporate entities are owning, quote unquote, are owning medical practices? And this gets to sort of the central way, the principal way that we've seen an erosion over the last few decades of these corporate practice of medicine bans. And essentially what's happened here is that these laws are still on the books, as I mentioned, where practices, where medical practices have to be owned by licensed physicians in the state. But what's increasingly happening is that corporate entities are using a different corporate vehicle, typically management services organizations, to exercise control, to take sort of de facto control over the medical practice. And the most extreme version that we see here is that the management services organization, which is typically there just to provide services to a medical practice, the professional corporation, that management services organization may just find one of its physician employees and install them as the owner, the friendly physician of the professional corporation, but will use that management services organization to functionally control the practice, while nonetheless satisfying this requirement, this legal requirement in the states that the physician practice is owned by a licensed clinician in that state. So it's that model, Aaron, if you want to flip to the next slide. So it's that model or that loophole, as it's best characterized, that the model legislation is trying to address. Again, trying to essentially restore the spirit of these laws in states, which again say that medical practices are supposed to be owned, or which in fact require that medical practices are owned by physicians and other licensed clinicians in the state. So a couple of provisions that I'll take through the sort of main components of the model here. The first is just to clarify this CPOM prohibition. Depending on the states, the sort of clarity of the CPOM prohibition ranges. It might be that the state quite explicitly says that in statute that medical practices are to be owned by a majority or exclusively by physicians. In other states, this doctrine is expressed really through sort of vague doctrine in the court. So the first component is just specifying and just clarifying that unlicensed lay entities are prohibited from owning, employing, or controlling medical practices or interfering with clinical decision making. The second component is really the meat of the substance of the bill, and there's kind of two tracks that this aspect of the model legislation takes. The first is just identifying a set of contracting practices that are used by these management services organizations to assume de facto control over the medical practice. So I described one of them earlier, where the management services organization will essentially install one of its own employees as the owner on paper of the professional corporation. So the model law would ban that arrangement explicitly. Another way in which we see management services organizations sort of invert this relationship, this principal agent relationship between the professional corporation and the management services organization. Another way we see that inverted is through the use of stock transfer restriction agreements. So this is where through contracting, the management services organization entity will essentially control in various ways what the physician owners can do with their equity in the practice. So that's another contracting component that would be banned in this legislation. And then also other forms of contracting like non-competes and gag clauses that allow the MSO to control the professional corporation or the physician practice. The other set of the sort of other component of this of regulating the friendly PC structure is specifying certain forms of activity that the MSO or certain conduct that the MSO might assume control over, that would again result in the MSO taking functional sort of de facto control of the medical practice. And here, to be clear, the model legislation is not meant to and doesn't in any way ban the role of management services organizations. So I just want to reiterate the intent here is to restore this relationship between the professional corporation and the MSO. It's not that MSOs can't exist. It's that the idea is to restore this intent that the professional corporation is the owner of the medical practice. And insofar as it wants to use management services organizations to provide services to it, it can. And that's what the second component of this regulation of this friendly PC regulation does, where it essentially says there's certain types of activities in a medical practice that must be retained within the professional corporation, within the physicians that own the practice. And these are things such as making decisions around clinician personnel, so hiring and firing decisions, or making decisions around how long the physicians and other clinicians have to spend with their patients, or making ultimate decisions over diagnosis and coding practices. These are things that potentially an MSO can assist with, but what the model legislation states is that ultimate decision-making authority over these activities has to be retained within the physicians who own the medical practice. And then the third component of the bill discusses protections for physicians in instances where the state decides to allow employment of clinicians. So, for example, a lot of states have exempted, for example, hospitals from this requirement that the entity is owned by, that the medical entity is owned by physicians and other clinicians. But in the instance where the state wants to permit employment of physicians, for example, in a nonprofit hospital, the bill does propose a series of protections similar to the protections of professional corporations for those physicians. So again, this might be non-competes and gag clauses, other forms of interference that the states are worried about that might be exercised by an employer over the physicians in an institution. And then the last component of the CPOM component of the model legislation is around enforcement. And we propose various forms of enforcement here, including the Attorney General, the administrative agencies, as well as private individuals. So the Attorney General has the authority under the model, or the administrative agency, depending on their merger review transaction law, to essentially take these factors of corporate control into their assessment of whether they're going to review and block or conditionally approve or approve outright a given transaction. So this is where the law sort of intersects with the first section of the bill that Aaron discussed. Another form of enforcement that the model proposes is just imposing, having the ability, the Attorney General having the ability, or the administrative agency having the ability to investigate and impose fines where there is a violation of these provisions. And then the last that we propose is what's known as a private right of action, and particularly for physicians and other clinicians, given the opaque nature of some of these interactions and the fact that it's really the clinicians who are going to understand whether a management services organization is crossing over that line between just providing a service to them that helps them run their practice and actually exercising control over the decisions that really implicate clinical care. Providing a private right of action for those clinicians to be able to sue and try to enjoin a practice, again, where a management services organization is exercising impermissible control over their control of their medical practice. Aaron, back to you.
Great. Thanks, Hayden, for that overview. And so then we will talk about part 3, and then I'll give a little bit of insight as to where some of these examples of whether state legislation or proposed bills that we might have seen that might give some color behind some of these efforts. So the last part of the model is transparency of ownership and control of healthcare entities. And in some ways, this isn't, even though we've said this is a standalone, that each piece sort of interacts with each other, this is the one that in some ways undergirds both of the other pieces, because without transparency, you cannot regulate, you cannot provide oversight, and it's hard to enforce any of these policies that are discussed elsewhere. So this might, even though it's placed as part 3, might be a good starting point for states that are just interested in learning more about the extent of corporatization or consolidation and corporate control in their healthcare markets. So the third policy is to require greater transparency of the ownership and control interests that exist already within the state. So this is, again, to enable the policymakers, the regulators, the enforcers, and the public, frankly, to know who owns or controls their healthcare providers. Even though there has been a fair amount of research already, particularly into the private equity entry into physician markets and other types of healthcare markets, even health services researchers and the most sophisticated health oversight bodies have to use a combination of manual, time-consuming data search tools and expensive proprietary databases to get a sense of the degree of, say, private equity penetration within a state. If you are a patient and you want to look up whether your doctor or if your hospital or hospice or ambulatory surgery center is private equity owned, there is no searchable database to be able to find this information. So the policy here is to require all existing providers licensed in the state, including physicians and entities, to report information on ownership and control relationships, including trying to penetrate all the complicated layers and webs of contractual affiliations that can be used, frankly, to obfuscate transparency and accountability and make it more difficult to find out who is sort of the ultimate control entity. So in addition to a baseline mapping of these relationships, there would also, of course, be a requirement to report on any changes to any ownership or control, either as part of a material change transaction if a state already has or is pursuing market oversight under Part 1, or just as a standalone basis if it doesn't already have that prior notice and review, but any changes to ownership and control would have to be reported. And make all of this available. The third piece is to make all of this available to the public so that the public and researchers and others can study this information. And so it's not just available to the enforcers and the regulators, but also to the public so that it can inform further policy. All right, so the part of the NASHB model that really gets into this, of course, is part 3, and it's designed to facilitate transparency of ownership and control of healthcare provider entities. And this is all based on, we have one state example to work with, and that's the Massachusetts Provider Registry. And where there is some limited ownership in a variety of sources on skilled nursing facilities, maybe even hospitals, but under federal law, this information is particularly lacking for physicians and provider organizations. So that in some ways is one of the big gaps that this is trying to fill. So part 3 of this model requires healthcare market participants, defined fairly broadly, to report ownership and control to the Department of Health or another designated state healthcare entity. And the applicability, again, focuses on group practices, but also applies to hospitals, health systems, nursing facilities, insurers, PBMs, and other big market participants in the healthcare space. The frequency, the state, of course, can decide upon this. The model defaults to an annual notification, but it could be biannual or every couple years, but also upon any material change notice. And the required information here is the important part. It's not just for owners, because as we heard from Hayden, a lot of the particularly physician practice relationships that exert control over these practices are not structured as on-paper ownership. So it has to go beyond simply ownership, but also seek to address those contractual affiliations that amount to control. And also the information has to be granular enough to be able to trace it down to the level of the individual clinician. So the name, the location, the taxpayer identification number, the national provider identification, the employer identification number, and then any other sort of industry standard identifiers like the NIAC, the NAIC number if it's a payer-affiliated entity, and then significant equity investors and control entities and MSOs. So these would try to get at the financial investors, whether it's private equity or venture capital or a publicly traded firm that has a significant amount of equity invested in that amounts to control over that entity, which of course has to be defined in the law. And then providing a corporate organization chart that includes a map of subsidiaries, entities under common control, and financial report, and basic financial information about these entities. So a map could be drawn, right? So that the idea is that the that the full org chart surrounding these entities, all the way up to its ultimate investor, can be understood by regulators and the public. Enforcement here is also placed within the state's discretion, but the model puts it at first in either the Department of Health or a health commission that has the ability to impose administrative penalties for non-reporting, and to also audit the accuracy and veracity of the information. So the last slide just talks about the first 3 lines are the parts of the model, and the last one is another related NASHB model, a different NASHB model, but is sort of another set of tools that NASHB can has provided a model for in terms of ways for states to address private equity, but also corporatization and other types of consolidation in healthcare. So the state examples for number 1, the part 1 entity oversight, we list the 3 states that have probably gone the farthest here, Massachusetts, Oregon, and California, but other states have other forms of enhanced oversight, and those are listed here. The policy concern, of course, this is the same slide as the first one, but it just includes some of the state examples. Many of these states don't go as far as the new NASHB model. And so some of these would be good sort of starting points, but in many cases, the NASHB model would be out in front in terms of addressing things like sale leasebacks or explicitly addressing management services organizations. The second part, corporate practice of medicine, laws and other types of professional protections, again, designed to protect professional autonomy of the physician and other healthcare workforce. There are here bills, but not necessarily laws that have been written into law. So Oregon had a bill in 2024 listed here. Massachusetts and California all had bills that either advanced either completely out of the legislature but were vetoed, or advanced through the legislative process, but weren't ultimately passed. But they provide some useful examples of how states are starting to think about how it would strengthen the corporate practice of medicine protections, paired with restrictive covenant protections along the lines that the NASHB model is pursuing. And then ownership transparency. Here, again, the baseline example from which we were operating is the Massachusetts Provider Registry. But even Massachusetts, again, was attempting this year to update the provider registry requirements in 2 bills that are listed here. And Indiana also had a bill introduced this year that would have improved ownership transparency. Again, didn't pass, but it was introduced. So again, these are all good examples, and our understanding is that there's a lot of interest at the state level in these tools. And so we would be happy to answer any questions that have arisen through our discussion. I'm going to stop the screen share so we can have a conversation.
Thank you very much. And I welcome both Hayden and Aaron to stay on video while we talk about this. We have some great questions in the chat, and I'm also going to supplement some of them but with questions that NASHB's received from state officials in other conversations we've had. The first one, I'm going to pull from the chat. We have also received similar questions too. So there is a question: if states are already enforcing the corporate practice of medicine and or reviewing transactions, this question is specifically that involve MSO supported practices. Oh, and sorry, it just moved. Why are additional codified restrictions necessary from a policy perspective? So I'm just going to ask that question to Aaron and Hayden and then supplement with another one in a second. If a state is already actively enforcing corporate practice of medicine and or reviewing transactions with MSO, why pursue additional codification?
Hayden, do you want to take a first stab at that?
Sure.
One?
Yeah, and we appreciate the question. I'll address the CPOM part. So the type of CPOM potential violation that we describe and that we attempt to address here is not being enforced, quote unquote, by any state right now. So this model, again, where the management services organization is essentially taking de facto control of the practice, in no state is that actually being enforced to prohibit that sort of model. A couple states get close to it. There's been some litigation in both California and Texas where there are particularly egregious violations of the use of management services organizations. But through statute, which would be the most comprehensive way of actually addressing this problem, we don't currently see any states that have basically updated their CPOM laws to address this newer sort of workaround. So that's really why we have it in the model here. It is correct to state that there's a varying degree of CPOM enforcement, but again, no state has actually closed this particular loophole, which is the principal way that CPOM bans have been eroded.
And there's just an advantage, generally speaking, to codifying certain standards that might exist in common law in states like California into statute, and that is it sort of makes enforcement easier, right? You don't have to bring individual case-by-case determinations and relitigate every time whether a certain contractual, let's say, stock transfer restriction agreement, in fact, amounts to de facto control that violates the corporate practice of medicine. And so even though, yes, common law is law, it's harder to enforce rather than just sort of declaring a certain set of practices and to be to have just as a matter of public policy to be unenforceable or to be against public policy. So on the question about if a state's already reviewing transactions involving, say, provider organizations and management services organizations, why would they need to pursue further enhancement to that authority? And I would say there's probably only one state that is doing the whole thing, and even that, and that's Oregon, in the sense that it has both the ability to review transactions that involve management services organizations and provider organizations, and the authority to block those transactions. But even then, I think a lot of the additional requirements. It's not clear, for example, whether any state receives prior notice in the same material change transaction of sale leasebacks or real estate investment trust arrangements, whether closures are considered a type of action that requires oversight and review to the same extent as, say, a merger or affiliation. And so in some ways, when we talk to states, even some of the leading states, about what additional authority they think they need, that's where it came from.
And to put a really fine point on it, states that have antitrust statutes and that they're actively reviewing for antitrust, Erin, some of the comments that you just made would be related to that too. That even though a state is actively pursuing antitrust violations, there are activities like those you just described that are not that the state doesn't have any authority to do some oversight on, doesn't have any enforcement with. So that's another reason why states came to us asking for these additional provisions being put into this model. But any other comments you have on how this market oversight works with traditional antitrust enforcement?
Yeah, I think the other issue is that, with the exception of a couple of states that have defined the threshold for notice at a pretty low dollar threshold, I think like $10 million to be notified of a transaction, a lot of states have a pretty high threshold or don't explicitly receive notice of, say, a private equity or a payer investment in a physician practice, either because the dollar amount is too small, it doesn't rise to the level of notice, it's just too small a transaction, or because the state only explicitly requires prior notice and review if it involves a health nonprofit hospital or other type of entity. So I think, again, this is kind of when we kind of surveyed the landscape, even the states with the strongest authority under antitrust review or other market oversight identified that there are some gaps that are pretty big that this model is trying to close.
We also got a really great question and recognize that there are states that have oversight of healthcare mergers and acquisitions that fall below what antitrust would be, but that some of those states, very few, I think it's only Oregon, has actual ability and authority to approve, deny, or condition a transaction from moving forward. If a state has authority that falls short of that, recognizing how challenging it can be in a legislative environment, is, from your opinion, would that be something a state should pursue?
Yeah, I mean, I think it's certainly, if a state has the authority to receive notice of those, of a broader range of transactions and the authority to study them, and then of course, if the Attorney General or some other entity thinks that it is, usually it's the Attorney General thinks that there is an antitrust basis to challenge the transaction, they can always bring that challenge. So it's not that a state is without any tools. And the reason why it might be advantageous, although again, not without controversy, from the provider community and from other investors in the space, the reason it might be desirable to put in place additional authority to block or impose conditions upon a transaction without going to court is how resource intensive litigation to enforce, even for the Attorney General's office, they have to pick and choose. These are very, very time consuming, resource intensive efforts. And so just the sheer amount of oversight they can provide is much diminished if they're relying on having to seek and obtain a court order every time they want to, again, reach a consent decree or a settlement agreement with an entity over its proposed transaction, versus having the administrative authority to do that, again, upon a reasoned set of criteria that would in some ways provide more oversight and be able to reach more transactions. And a lot of times, as we see in Oregon, that's not used. I don't think Oregon's not blocked a transaction yet. It's used sparingly, but the conditional approval authority is quite powerful in the sense that a lot of oversight is done through the imposition of conditions to avoid some of the market or the adverse effects to the public interest that are of concern.
Thank you. And I think this one we may start with Hayden, but welcome both of you to weigh in. The question is, why is it seen as a risk to healthcare quality if an MSO contract limits a physician's power to sell stock or options in that practice?
Yeah, thanks for that question. So I think it's most helpful to think about this again from the overall intent of the legislation here. And again, the idea is to breathe life into these state statutes that say that physicians own their medical practice. And for a whole host of reasons, the state legislatures has evinced this intent that that medical practices are owned by physicians because all these decisions that are made in a medical practice implicate the quality of care, a lot of which we've discussed here. The decision about how long a physician should be able to spend with their patients, or decisions around diagnosis in treatment, or decisions around, for example, clinical staffing and how many clinicians are in the office. So the idea of the law is to make sure that those physicians are actually de facto or actually functionally controlling that medical practice. And when you see certain contracting arrangements like stock transfer restriction agreements, where a separate lay entity, this management organization, essentially exercises control over what physicians can do with those shares, you begin to, again, invert this relationship. You subordinate the physician owners of a practice to the management services organization, because the management services organization, through contract, is now basically saying, I have control over the physician's equity in the practice. So that's why provisions like this, again, are contrary to the intent here that the physicians own the medical practice, and therefore the principals are the ones making the ultimate decisions about all sorts of things that occur in the practice. And again, insofar as they want to use management services organizations, which is absolutely permitted, in fact, and maybe encouraged in many instances, just having those management services organizations provide the services to the practice that the practices want, rather than, again, legally taking control over the equity of the physician practice. Hopefully that makes sense.
I think that was very helpful. Thank you. We have a question. Have any states successfully created regulations in this space? And I'm going to assume that's broad, corporate practice of medicine, as well as market oversight, only for a specific subset of facilities, such as behavioral health, long-term care services, or is it seen as essential to tackle the system as a whole?
I'm not aware of any state that has created sort of be analog to this type of market oversight or other types of protections, but only in the context of one type of provider. I think maybe there's an exception there in terms of there is some special rules for nursing facilities, I think because of the special vulnerable population, and the sort of staffing levels and the degree of corporate investment in nursing homes. But I think that for the most part, this is generally seen as a market-wide either problem or phenomenon. And so in some ways, to limit oversight either to a particular type of investor, there was an attempt, obviously, in California this past session to do that, to just really target private equity and venture capital on its own, but not other types of investment. But as I think most states that have approached this issue have done so with a sort of market-wide lens. And the reason is that investment moves, market trends move across, and a lot of these consolidations are happening across different provider types and different entities and across different types of corporate arrangements. And so if you were to restrict oversight to just one particular, niche of the market, whether that's behavioral health or primary care or something else of concern, in some ways it might inadvertently move the market into into different places that have no oversight or less oversight, and that may be an unintended consequence.
So we have received this question in regular conversations with states that there are just a question about culture in a state that may be anti-regulation or free market. However, there are concerns about increased consolidation, driving up price. There are concerns about corporate practice of medicine. Any ideas on how to approach a legislature that is pro-free market, but clearly has concerns about what's happening in their market?
Yeah, I think, and I'll let Hayden weigh in as well. I think that, what we've seen is we've been hearing from states that sort of cross the political and business orientation market spectrum, because I think this is a problem, the consolidation and the influence of corporatization, the physician workforce crisis. This is a problem that is borne by states regardless of political leadership. And so I think that states are truly grasping for whatever tools they can. However, point well taken that the sort of presentation of this, a suite of policy options or even a particular policy option is more difficult in states that rely on free markets. But I think the way to approach that is to point out the degree to which the market may not be functioning quite as competitively as we would like. And so I think starting with transparency is always a place that I think has bipartisan support. Almost no one is opposed to more information and more understanding as a sort of a pathway to even study the degree to which these actors are in a state. I think that is very motivating for legislators if they see the degree to which, for example, private equity or other types of corporate investments have made inroads into their district or into their major provider groups. I think that is a wake-up call. It moves it from being abstract to being concrete. And then the conversation about, well, then how do we protect the physicians? Again, as Hayden said, not by pushing out MSOs, not by pushing out private equity capital, but by really just sort of putting some guardrails around that type of investment is a different conversation when you have the data.
Yeah, I would just add a couple points on the CPOM front. The first is that this doctrine actually crosses political valences quite a bit. So the two main states that are understood to really robustly enforce their corporate practice of medicine bans are California and Texas. Very different political environments there. The second point I would make relates to I think a point Aaron made, which is I think the way that, our laws are always structuring all of our markets. And I think the ways to, these markets exist downstream of whatever sort of rules or laws we structure to make them function. And I think the way to think about CPOM is really trying to ensure that the type of private investment we have in the medical system is productive and promotes, societally beneficial ends or promotes what the state wants to see in their healthcare system. And to be more specific there, for example, it's really trying to channel investment towards, for example, the traditional functions of a management services organization. So channeling that investment to innovation or technology that would allow an MSO to provide a better service to those medical practices and market those services to the medical practice and try to get the business of the medical practice because, for example, they can provide some sort of technology or some tool that's going to help the medical practice run. What we don't necessarily want, or what these laws try to get at, are ways in which the management services organization again might control decisions that the state law has already said are supposed to be within the purview of the medical practice. And another way of sort of looking at that too is is trying to promote forms of fair competition. So one way of comparing this is if you're a private medical practice and you might be in an unfair playing field with, for example, a private equity owned staffing company that might engage in a whole host of practices that you as a physician practice might see as unethical or just difficult to enact as a physician practice. So, part of these laws is trying to level that or trying to draw on this concept of fair competition to allow a truly physician-owned practice to operate in the medical system with all its other competitors.
Thank you so much for those comments. Really appreciate it. I will note that we have gotten several questions along a very specific theme, which is that corporate practice of medicine legislation and the policy that is in NASHP's model law does not specifically speak to the hospital-owned physicians. And there are questions about how to address hospital-owned physicians and if there's any suggestions on types of regulation or if corporate practice of medicine could be used to address giving protections to providers that are affiliated directly with hospitals.
Yeah, so we provide basically two avenues for the hospital concern here. The first is to do what a couple states currently do now. I mentioned Texas and California. So in those states, they're certainly the minority. They actually do apply their CPOM ban to hospitals. And this is why they're thought to have a stronger, a more robust doctrine. It's one of a couple reasons. But again, what they don't yet do is regulate this friendly PC model. But they do essentially say that hospitals, like other corporate entities, can't employ physicians. What we've seen, however, is the same sort of workaround that we see in the medical practice context. So in this context, the hospital, essentially think of it as the hospital is now operating as the management services organization, and they will essentially create install a professional corporation and control that professional corporation from the lay-owned management services organization, or in this context, the lay-owned hospital. So one way of addressing that concern, that workaround, again, in a state that says we don't want hospitals actually employing physicians, is to apply the same restrictions that we apply to the friendly PC model. So you essentially say, here's an updated way to essentially to breathe life into this idea that the lay entity actually can't control the separate entity of the physician-owned practice. So that's option number one. Option number two that we propose, recognizing that so many hospitals employ so many physicians, and there might be reasons why a state might want to allow hospitals to own their physicians. This gets to, I think, that third component of the law, where you essentially say, in the instances where the entity is employing physicians, here are a whole suite of practices that we might want to prohibit the employer from enacting. And it's a very similar list, again, as we apply in the PC MSO setting. So non-competes and gag clauses for employed physicians, or restrictions around the degree to which for example, the hospital executives can require that physicians see patients in a certain amount of time, decisions around when they discharge their patients, all sorts of things that fall into this general, I think, in kind of indicia of control that we're trying to leave within the decision-making authority of the clinicians.
That's great. Thank you. And there is a question here that there are several provisions within the model that mention insurers. Assuming this includes employment-based self-insure plans, are there ERISA concerns?
Yeah, I think that there, certainly if it's the sort of reporting, we've seen in the Gobet case that, self-funded employer-based plans cannot be required to submit their claims data to the state APCD. And so under similar reasoning, it might call into question whether or not a self-funded plan could be required to report ownership information to the provider registry in that context. I think what we're more concerned about is the idea that the insurer as purchaser or investor in a provider organization. So that's where the sort of real, we thought very carefully to make sure that we include insurer-backed groups because, for example, as we all know, United is an insurance company and Optum is the largest either employer or management service organization of physician practices in the country. So if the model were to leave out the Optums of the world, it would leave out a big part of this phenomenon. And so insofar as the insurer may be, affiliated with a self-funded plan or serve as the TPA for the self-funded plan, but the insurer is really in its role as Optum, it's not doing its insurance function. It's not being a TPA. What it's doing is it's really building up its provider practice, affiliated provider practice. Maybe it's serving as a provider IPA or independent practice provider association, but it's really sort of functioning more as a provider in that sense. So we're pushing on the idea that states have a lot more leeway to require notification and oversight over provider entities, provider groups. And so to the extent that a payer enters the market as a provider investor or enters into transactions with providers, then that also would, I think it would fall on the side of provider regulation. The other piece of it is that many states already have and this is just sort of a side, it's not the ERISA question, but just to point out a nuance of the law, is to the extent the state already has a Department of Insurance function for reviewing true insurer transactions, like an insurance plan merging with another insurance plan or a PBM transaction that falls within the jurisdiction of the Department of Insurance, that this model would sort of defer or incorporate that process and sort of allow conversation between the respective agencies to be able to come up with the assessment and review and recommendations for those types of transactions. But we're really concerned about in this one is those transactions when they implicate providers of any sort.
This has been excellent. Thank you so much. I am aware of the time. We did get through most of the questions. There are a couple that NASHP can follow up on. But I really want to extend a huge thank you to Erin and Hayden, really for your work with our work group, for your patience, for your really keen sense of listening to what states' needs were, listening to the solutions that they were putting forward, and then really thinking creatively about how to incorporate all that states wanted to incorporate into this model, recognizing that, as we said at the top, it is intended for states to be able to adapt. It is intended for states to be able to negotiate. It is intended for states to be able to take pieces of that work in their systems for their goals and that address the issues that they're seeing. But we really appreciate your thoughtfulness today and throughout all of this process. So thank you for your time. And I want to thank the audience for some really great questions. We look forward to connecting with everyone soon. Thank you, everyone. Bye-bye.